Genitourinary by Dr. Hargraves. Our learning outcomes are to identify growth and development, health promotion needs, and alterations in health for children with gastrointestinal or genitourinary system alterations. Develop family-centered nursing care for children with gastrointestinal or genitourinary system alterations. Apply the nursing process when caring for children with gastrointestinal or genitourinary system alterations, and apply evidence-based practice to care for children with gastrointestinal or genitourinary alterations. We'll start with hypospadias. This is where the urinary meatus is located on the ventral surface or underneath the penis or somewhere along the penile shaft. Our goal is to repair this before they have potty training, so that when the child is potty training, the urine will come out the tip of the penis and they can aim better. These children, they don't do circumcision on these kids if the parents are requesting it, because they use that foreskin to help build the repair, because they're going to have to stretch the urinary meatus all the way down to the tip of the penis. Epispadias is the other side of the penis, so that's on the top part, and that's significantly less common. Here's a picture of a penis. And then here's the repair. So you can see it's not a simple surgery. It goes down into the scrotum also. Genitourinary congenital conditions. So I can't say this one. Cryptorchidism is an undescended testes. This is where one of the testicles or both stay in the abdomen instead of going through the inguinal canal into the testicular sac. It's more common in premature babies or babies who are low birth weight or twins, and it can also run in families. Sometimes the testicle will come down on its own. Usually they'll have to do an orchiopexy, which is a surgical procedure, and they usually do this in infancy. And they need to do the surgery because if they leave that testicle in the abdomen, it's a high risk for cancer. And then we have exstrophy of the bladder. That is where the bladder, the skin and the bones don't close over the bladder. So the bladder is outside, right? That's extro. And it's a congenital defect. You can see that with this baby, it's kind of a widened whole pelvic area there. They usually need multiple corrective surgeries. It's not usually one simple surgery to fix this. And then urinary tract infections, which I know you are familiar with in adults. Really same information, almost exactly the same. I've got a diagram on the left there that shows you the lower tract, which is the urethra and the bladder, so urethritis and cystitis, and then the upper tract, which is up into the kidneys from the ureters, and that's pyelonephritis if it gets into the kidneys. It is E. coli in about 80% of the cases, so that means it's a bacteria that is most likely coming from stool in the same patient. As you know, it's much more common in females, and also in uncircumcised boys, just because debris sits under the foreskin if it's not cleaned correctly. Some of the other risk factors are vesico-urethral reflux, which basically means the bladder squeezes and urine goes back up towards the kidneys, so that makes sense. A neurogenic bladder, where the bladder does not empty all the way, so that's common in spinal cord injuries, or in our case with pediatrics, it's common in kids with spina bifida, which I'll talk about in a week or two. Can be more common in constipation and infrequent voiding, so lack of enough fluid intake or just letting a lot of urine gather in the bladder gives just more opportunity for bacteria to grow. And so what do we do for our nursing assessment? Well, we're going to assess signs and symptoms. So nausea, vomiting, anorexia, chills, nocturia, urinary frequency, and urgency. Although a lot of people that have this don't realize they have a urinary tract infection. Suprapubic or lower back pain, bladder spasms, dysuria, burning on urination. And then our objective data, so we should be able to appreciate a fever, hematuria, so a little bit of blood in there, foul-smelling urine, sometimes a tender enlarged kidney, leukocytosis. They might find, doing a urinalysis and a culture, they could find some bacteria, white blood cells, red blood cells, etc. And there's additional workup we could do. So is it really that serious? Yes, because we know that a lot of urinary tract infections, if not treated, go into sepsis. So the bacteria crosses from the urinary tract system into the blood and then causes sepsis in patients. And we see this a lot in older adults also. And one of the main signs and symptoms in adults is that it is confusion. Let's see. There are some comments in the notes section of this slide, if you want to look at them in the other slides. Concept of asymptomatic bacteria. So some patients, particularly if they are cast on a regular basis, will have bacteria in there, but it's not like, it's like a colonized, we call it colonized bacteria. So they'll have a little colony of bacteria in there, but it doesn't, like take over. And so it's, that's a colonization. And then asymptomatic bacteria means it's growing in there and they don't actually have any symptoms. So we have a question. When observing manifestations of a urinary tract infection in a 24-month-old, what might the student nurse expect to see? Select all that apply. Okay, so it's all of them except not thirsty. So it includes painful urination, poor feedings, frequent urination, fever, foul-smelling urine, and then in the notes I have a few more like vomiting, failure to gain weight, straining or screaming on urination, pallor, persistent diaper rash, seizure with or without fever, dehydration, and enlarged kidneys or bladder. So basically we want to treat our urinary tract infections. Okay, what is the primary cause? Well, it's E. coli. That's that pretty pink one up there. E. coli is a gram-negative rod. And then streptococci and staphylococci. And I think, I can't remember which one of those is, oh, let's see. Staph is on the right side, the big one. That's actually methicillin-resistant Staph aureus. And then streptococci is the one that looks like a bunch of beads on a string there. Sometimes it'll be fungal or parasitic. That's not very common. So we're going to check their, so 40% of them are asymptomatic. We're going to do, this is a urinalysis, a cheap one. You can buy these over the counter. And usually you'll see some blood in it and maybe some other symptoms. This is a little repetitious from previous ones with some fancier language like pyrexia, pyuria, hematuria, dysuria, urinary frequency, and foul-smelling urine. But then if it's in the kidney, then it's a lot more serious and it causes a lot more pain and it needs to be treated maybe a little bit more aggressively. And that's when it can really go into sepsis. So you can see it has chills and fever, fatigue, and emesis. What other kinds of diagnostic testing do we do? Well, we start with a clean catch urine, and then we need a urine culture. For kids, we will typically do an in and out catheterization if they're not potty trained. Although I did find a video of a doctor who does something with a baby and he can stimulate the bladder. And so I think it's a nerve response, which if I were still practicing, I would probably learn how to do it and see if I could do it. But basically, if the child isn't well enough controlled to be able to pee either on command or when they say I have to pee and you be able to catch a midstream urine, we're going to put a catheter in. Further diagnostics, a renal ultrasound, so to see what the kidneys look like. Is the kidney pelvis there, is it enlarged, right, as if there's backflow in it? Avoiding cystourethrogram is one where where I think they shoot some dye up there or something, but basically they watch or they put dye in the bladder, and I think they watch to see if it regurges up there. And so this is a grade 2 one where you can see it's purple up into the kidney. Okay. And how do we manage it? Well, our goal really is to prevent any kind of renal scarring, because scarring will affect renal output. So usually 10 days of antibiotics. If they're in the hospital, we'll give them IV, which is usually ceftriaxone. And if it's oral, then they can take Bactrim or Keflex. Deflux, if necessary, is here. They do this with the voiding cystourethrogram. They inject a little bit of it. It's a sugar-based medicine, and they put it right at where the ureter enters into the bladder from the kidney, and somehow it occludes it, or something does something, irritates it maybe, and stops that backflow. So that does work okay. Do follow-up urine cultures every 1 to 2 years on kids who have chronic problems. If it's really bad, they might be on prophylaxis. And really education, most parents know and are taught at some point, teach the girls how to wipe from front to back. That's the biggest problem. Teach boys to wipe and keep it clean. So here's another question. The single most important host factor influencing the occurrence of a urinary tract infection is what? Okay, so it's urinary stasis. That's where urine stays in the bladder. So think neurogenic bladder. So the bladder doesn't have enough to empty all the way, enough musculature or innervation, or holding on to urine and not peeing. And so it sits in there and has more opportunity for bacteria to grow. Okay, there is additional information in the notes here. It explains why the other ones are incorrect. Okay, so let's talk about kidney failure in children, or kidney problems. Nephrotic syndrome is one of the ones that affects children primarily. And the way I understand it, again, you guys know I like pictures. If you look at the pictures there of the colloid osmotic pressure and pretend those are the legs of your patient, then you look at the top one and you can see that there's no swelling, and you can see that the loop is that the fluids are going back in. The colloids are inside and inside the blood vessel. Nephrotic syndrome. So if you look at the diagram first, you can see that it's a blood vessel in the center. That's the red part. And you can see that the colloids are inside the blood vessel on the top. And that, if you, for instance, said that's the leg, you can see that the leg is nice and straight. When there's low albumin, it's leaked out into the tissue, or there are more colloids out in the tissue. And so fluid goes out into the tissue, and that causes swelling. So that's what happens in nephrotic syndrome. We don't know the cause, which is idiopathic. That's what that means. It has abnormal protein leak, right? So the albumin is leaking out, then resulting in hypoalbuminemia and hyperlipidemia. So the fats don't leak out, so they're higher concentration in the bloodstream. These patients have significant edema, and they lose some of their albumin in the urine. So the loss of protein increases the synthesis of lipids and decreases the oncotic pressure, which causes edema and hypovolemia. So this is what a kid might look like. Often the first sign that parents really see is their kid's face swelling. So this little guy's got swelling under his eyes there that looks pretty significant. And then you can see how puffy the legs are. There are very few disorders in kids that cause a significant amount of edema, and this is the main one. They'll gain a fair amount of weight over a short period of time, and the skin gets stretched out. Their shoes might not fit, their clothes might not fit. Again, the edema starts near their eyes and then progresses to generalized edema. It's leaky blood vessels, so they're going to start to have some respiratory difficulty. And they have a dark, frothy urine, but their output is decreased. So they're hanging on to the fluid. And what do we do for them? Well, we put them on a corticosteroid and we give them a no added salt diet. And then usually we'll give them some IV albumin followed with a diuretic. So the albumin goes into the bloodstream. Even if some of it's getting cleared out in the kidneys, it still has the opportunity to suck some fluid in. Then we give them Lasix usually, and they dump out a whole bunch of this excess fluid. And then we just keep them on treatment for a while. And then our second kidney failure or kidney problems is acute glomerulonephritis. Okay, acute glomerulonephritis is a common illness, kidney illness in kids, and it's where the immune complexes get deposited in the glomerular basement membrane in the kidney, and that leads to an occlusion. Most often, it is going to be after an infection. It is the kid who had strep or something like that, or has lupus or diabetes, and has this antigen antibody complex from the disease that then gets stuck in the glomerulus. And they have a sudden onset of hematuria, so bloody urine, and they will also have hypertension and some mild or moderate edema, but not anything like the nephrotic syndrome has. What kind of diagnostics do we do? Well, we check the urine and it shows proteinuria and hematuria. And then we'll do blood tests. So we're going to do the ASO titer, which hopefully you guys remember now is the anti-streptolysin titer to see if there are antibodies to strep. Because if there are, then we're going to make sure they were treated with antibiotics for that. Azotemia, BUN creatinine, and maybe other labs. We look at the urine, it's going to be kind of this cloudy dark color. How do we prevent it? Well, we don't really know what's actually causing it. So this can happen even in kids who have a strep infection, as long as they're developing some antibodies to it. But maybe it's more common in kids who are untreated with untreated infection. How do we treat it? We're going to give diuretics. We'll do daily weights, blood pressure monitoring because this one causes hypertension. We're going to look at the diet and probably do no added salt or low salt and manage fluids. So when we compare the two of these, nephrotic syndrome and glomerulonephritis, we see that the main characteristics include edema for both of them, although it's much more significant in nephrotic syndrome. Both of them affect males a little bit more. And you can see that nephrotic syndrome is at a younger age, 2 to 7, and glomerulonephritis is more in school age. Also, glomerulonephritis has hematuria. And then the causes, we don't know really for nephrotic syndrome, and it could be congenital, and it can also reoccur. Glomerulonephritis, though, is a result of streptococcal infection. And then I'm not going to talk about the glomerular changes because I think I explained them on the other pages. Signs and symptoms now. For the nephrotic symptom, this is the kid that's going to gain a whole bunch of weight and have a lot of edema and have fluid in the lungs, so have fatigue, and that means decreased urine output. In glomerulonephritis, there's going to be a more mild edema and discolored urine and lethargy. And then how do we treat it? The nephrotic syndrome, we're going to treat with corticosteroids, and glomerulonephritis, we're going to treat with antihypertensives and diuretics. And then prognosis for the nephrotic syndrome is 80% favorable, and these kids sometimes relapse. And then glomerulonephritis is pretty good. We can save those kidneys quite well. Then we have hemolytic uremic syndrome. So this is my favorite because these kids are pretty sick, of course. Hemolytic uremic syndrome is caused by bacterial toxins, chemicals, or viruses. And one of the most common ones is E. coli 0157H7, which comes in undercooked meat, juice, lettuce, and contaminated water. And I usually pause at this time and ask the students to think about some of the foods that you've seen recalled or restaurants that have had to stop serving certain foods or have had an outbreak. And a lot of times it's going to be this is one of the causes that could be contributing to that. So what happens? This is where the toxin that's put off by the E. coli bacteria attaches to the glomeruloendothelium and damages that tissue. And then, right, it's damaged. So then it's going to have platelet aggregation, which leads to obstruction. And when it's obstructed, it damages red blood cells, and it has poor blood flow through the kidney. So the triad is hemolytic anemia, right? Because it's breaking the red blood cells. That's what's causing the anemia, hemolytic. Thrombocytopenia, which is low platelets, because a lot of them are stuck in the kidneys there trying to fix the damage. And acute renal failure, which means basically they stop peeing. How are we going to treat it? Oh, sorry, let me talk about the hamburger first. So first, one of the first times that this was really diagnosed and identified with this specific bacteria was Jack in the Box. And it was when you could get your hamburger at a fast food place, cooked rare, medium, or well done. And they were in the rare meat, there were E. coli, or sorry, this H10157, H7, and yeah, I don't like that. So treatment for HUS, we have to first focus on stopping where the contamination is coming from. And the original ones came from Jack in the Box on the West Coast here, where kids were coming in. I think we had 2 or 3 or 4 of them from Washington down to California who had eaten at a Jack in the Box. That's what they had in common, and had contracted this. And so they determined it was coming in the meat that was being served, not cooked thoroughly. How do we treat it? We give them some fresh frozen plasma because this is based on toxins that are in the bloodstream. So we're going to try and dilute out their blood. We're going to try and switch out some of their plasma. So then we do plasmapheresis, which is a machine that kind of looks like this dialysis machine. And so it's a short-term plasmapheresis, and we give them some FFP, and we take off some of their plasma to kind of filter it through. And then we would do dialysis if they have we would do this after 24 hours. Plasmapheresis, what does it do? This just tells you what it does. It depletes the inflammatory mediators, provision of deficient factors, reduces plasma viscosity, and decreases the opportunity for additional damage to the kidneys while we wait for the kidneys to get better. And then acute kidney injury. So primarily in kids, when they have acute kidney injury, it's going to be caused like this, as you can see, typically from some outside source, right? It's not directly on the kidney itself. So this is the picture I found to talk about this. I'm going to say they don't take a lot of nephrotoxic drugs in kids. Inflammation and vasculitis is maybe inflammation. Vasculitis is pretty unusual. Low blood volume is probably the main cause, the biggest cause. So low blood volume, maybe during cardiac surgery where the heart's not pumping well enough and they don't, after surgery or something like that. It's typically a result of trauma, something that results in low blood flow to the kidneys. And heart failure can cause it also, but as I've told you before, heart failure is not very common in kids. Wilms tumor, this one is just in here. I'm going to talk about it again when we get to cancer, but I have it here because it affects the kidneys. It is a tumor in the kidney, and it's typically diagnosed around 3 or 4, and that's because that's about the point where they're losing that big kind of round belly that a toddler has, and you start to see that there's a difference, and one side of the belly is higher than the other, which means the kidney is swollen. And on the right side, you can see the stages. Again, I'm going to talk about it when we get to kidneys, or when we get to cancer.